So investigations in anterior uveitis are often negative with no clear underlying cause determined in many patients. So rather than performing a battery-up screening test, investigation is tailored to each patient, directed by clinical features. Sometimes the likely cause may be obvious, such as severe anterior uveitis following intraocular surgery. So in that case, endophthalmitis will lead to the differential diagnosis list. In most cases, a careful review for systemic symptom is essential to detect any clues to underlying disease, with referral to a specialist physician for further assessment where appropriate. Many associations of uveitis can present with a wide range of systemic features. So in some cases, investigations are generally not indicated, like if there is a single episode of unilateral and mild to moderate. Mild to moderate means with no hypopyon, and if it is non-granulomatous and acute anterior uveitis. So in the first episode, investigation is not required, with no ocular or systemic suggestion of underlying disease. Typical clinical features of a specific entity for which investigation is not usually required, for example, Fuchs uveitis syndrome. A systemic diagnosis compatible with the clinical feature, for example, if there is sarcoidosis and it has already been confirmed. So in some situations, in some situations in which investigation of anterior uveitis is generally appropriate, that include recurrent uveitis, severe uveitis, bilateral acute anterior uveitis, anterior uveitis that is persistent, chronic, or resistant to treatment, and the last one, granulomatous inflammatory signs. Note that granulomatous conditions may give non-granulomatous also. So these are the conditions in which the investigation is generally appropriate. The ocular or systemic clinical features suggesting an underlying disease, so associated with intermediate or posterior uveitis. So if there is anterior as well as intermediate and posterior, if it is associated with ocular or systemic clinical features, repeating targetedly previously negative investigations several years later is sometimes helpful. So the investigations which we will do, the first one is human leukocyte antigen, HLA. So HLA tissue typing, or HLA-B27. It is the major histocompatibility complex, MHC. It is a group of genes involved in white cell antigen interaction and other immune functions, and including the encoding of cell surface glycoprotein. In human, the MHC is found on chromosome 6. It is called the human leukocyte antigen system, HLA system. The HLA typing is used to determine organ transplantation compatibility and can also indicate predisposition to particular disease. It has conventionally been performed by serological antigen identification, but it is increasingly involving analysis of DNA nowadays. Now the HLA-B27 is a common, and up to 6 to 8% of whites in the USA and 0.5% of patients of Japanese ethnic origin. So this HLA-B27 is a cell surface protein that presents peptides to T cells. The phenotype has a very strong association with acute anterior uveitis, ankylosing spondylitis, and some other inflammatory conditions such as reactive arthritis, also known as Ritter syndrome, psoriatic arthritis, and arthritis in the inflammatory bowel disease. Also, it is present in 50% of patients with acute anterior uveitis who are otherwise fit and well, and 90% of patients with AAU who have an associated spondyloarthropathy, notably ankylosing spondylitis. Many HLA B27 subtypes have been identified and their significance is subject to ongoing investigations. The HLA types associated with ocular inflammatory disease are listed here. HLA B27 testing should be performed in any adult or child with recurrent or chronic non-granulomatous anterior uveitis. HLA B27 is found in the recurrent acute anterior uveitis, A29 in birdshot retinochoroiditis, B51 in B5 Behçet syndrome, B7 and DR2 in presumed ocular histoplasmosis syndrome, HLA-DR4 in sympathetic ophthalmitis, and VKH syndrome. The next test is syphilis serology. The syphilis serology, so for this the treponemal antibody tests such as ELISA means enzyme elect immunosorbent assay. So the ELISA are highly sensitive and specific but take around 3 months to become positive. So, and the non-specific titratable cardiolipine antibody tests such as the rapid plasma reagent and venereal disease research laboratory, they are more commonly positive in early infection and are used to help monitor disease activity. These tests become negative over time. Typically in treated disease, false positive results can occur. Both categories of tests should be performed when screening for ocular syphilis. Clinical features suggesting a diagnosis of syphilis should prompt urgent referral to a physician specializing in infectious or sexually transmitted diseases. The next is serum angiotensin converting enzyme. Serum ACE is a non-specific test that indicates the presence of granulomatous disease such as sarcoidosis, tuberculosis, leprosy. Elevation occurs in up to 80% of patients with acute sarcoidosis but may be normal during remissions. In normal children, serum ACE levels tend to be higher and diagnostically less useful. Vigorous exercise can elevate ACE. There is lysozyme. It is a group of enzymes found in polymorphonuclear neutrophils and numerous secretions including tears. It has a strong antibacterial action mediating breakdown of the bacterial cell wall. Serum lysozyme assay is generally slightly less sensitive and specific than serum ACE in the diagnosis of sarcoidosis, but performing both tests may increase sensitivity and specificity. And there is ESR and CRP. These are acute phase reactants. They are probably of limited value but may be elevated in a range of systemic inflammatory disorders. Next is CBC. Leukocytosis may raise a suspicion of infection and malignancy and exceptionally hematological malignancy. Eosinophilia may occur in parasitic infection. Lyme disease. Serology may be considered particularly in the endemic areas. Serology for other infection disease such as brucellosis, leptospirosis can be requested if relevant risk factors are present in the endemic region. Next is ANA anti-nuclear antibody. It is of limited use except in children and those with juvenile idiopathic arthritis. Its presence is associated with the high risk of chronic anterior uveitis. Cases of possible subclinical JIA have been reported in ANA positive children with chronic anterior uveitis. Next is ANCA, anti-neutrophil cytoplasmic antibody, is a limited use in anterior uveitis unless associated with scleritis and or peripheral ulcerative keratitis. When cytoplasmic ANCA, C-ANCA testing should be considered as evidence of vaginal granulomatosis. Interferon gamma release assay, for example, quantiferon TB gold blood test for tuberculosis. HIV serology indicated for selective patients, usually those in whom opportunistic infection has been diagnosed or is suspected. Sacroiliac giant X-ray may show evidence of sacroiliitis in ankylosing spondylitis and other seronegative spondyloarthropathies. Chest X-ray may show evidence of sarcoidosis and tuberculosis. A high level of suspicion for both of these treatable conditions as well as syphilis should always be adopted, particularly if the inflammation is granulomatous. So in patients with sarcoidosis, bilateral hilar lymphadenopathy is the only finding on chest X-ray, significantly associated with age and gender. As it peaks at 30 to 39 years, it is more common in men. Bilateral hilar lymphadenopathy. Sarcoidosis in for tuberculosis. Ocular imaging, B-scan ultrasonography. If the posterior segment view is compromised by very small pupils or opaque media, optical coherence tomography may reveal posterior segment complications such as cystoid macular edema and epiretinal membrane. Fundus autofluorescence may demonstrate suspected posterior segment pathology, such as the lesion of severe inflammatory conditions such as multiple evanescent white dot syndrome, which may give mild AC inflammation, are often shown more effectively than on clinical examination. Fluorescein angiography is useful in some cases of anterior uveitis, such as the confirmation or exclusion of suspected posterior segment pathology. For example, vasculitis, white dot syndrome, identifying macular ischemia as the cause of reduced vision if no macular abnormality is visible on OCT. There is endocyanin green angiography is rarely indicated in anterior uveitis but might be used to look for subtle associated choroidal pathology. And there is ultrasound biomicroscopy is particularly indicated in case of hypotony and may demonstrate pathology such as subtle choroidal effusion, cyclodialysis, and cyclitic membrane. Cyclodialysis cleft here, and this is uveal effusion with choroidal detachment. This is the sclera. Aqueous tape is historically rarely performed in anterior uveitis, but viral causes are now recognized as being more frequent than previously realized. Herpes virus, including cytomegalovirus, rubella should be considered in clinically suspicious cases, especially in unexplained hypertensive uveitis and cases relatively unresponsive to topical steroid. An aqueous humor sample may be sent for polymerase chain reaction analysis or evidence of viral genetic material, and for microscopic culture and antibody assay. PCR may also help to exclude propion bacterium infection as a chronically inflamed pseudophakic eye. Iris biopsy is rarely performed. Vitreous biopsy tend to be confined to the investigation of obscure posterior segment inflammation and suspected infectious endophthalmitis. To determine the cause of persistent and severe posterior uveitis of unknown etiology, for which all a workup is negative, consider undertaking a vitreous or retinochoroidal biopsy. Conjunctival biopsy, sampling of tissue such as suspected granuloma or infiltrative lesion, is occasionally indicated. Referral to a specialist physician with resultant further investigation. This is vital when systemic disease is suspected. For instance, if respiratory symptoms are present, a chest physician may arrange additional testing such as high-resolution CT scan, whole-body gallium scan in sarcoidosis, purified protein derivative scan test for tuberculosis, but negative test is a diagnostic indicator in sarcoidosis. And bronchoscopy with lavage biopsy, similar neurological referral may lead to a cranial magnetic resonance imaging and lumbar puncture and gastroenterological referral to endoscopy.